For those of you who are on Twitter, the official hashtag for the conference is TCP15. So feel free to share what you're learning with the rest of the world because we support that. And those are just your housekeeping information again, the Wi-Fi code and the links to the schedule as well as the handouts. So what we're going to move into is talking about how do we approach a comatose patient. So let's say we get the patient back from a cardiac arrest, we cooled them, we rewarmed them, and now they're comatose. So what does that mean? What's important in their exam anyways? Let's see if we can shed a little bit of light on that. So the objectives of this next 18 minutes or so is to actually talk a little bit about how coma is actually a spectrum. We use this terminology very broadly, and especially in in the news and in the press and et cetera, things like that. But there's actually many differentiations about coma. We hear in the news about minimally conscious states, about persistent vegetative states, and that really all falls within the spectrum of what coma is. We're also going to talk a little bit about what entails my daily exam in the ICU and what I think would be good neurological exam of a comatose patient to get a sense of truly, what is involved, maybe how to localize the cause of the coma, as speaking like a neurologist. And then we're actually going to talk about something called the 4 score. How many of you are familiar with that? Okay, all right. It's actually been around for a little bit, and we'll talk a little bit about that. It's also a coma score, and I think it has quite much more robust value in terms of compared to the Glasgow coma scale that we're all used to. So all of us sitting here, I think so far, because we're just starting in the morning and we have coffee, we're still conscious. But the patient that we were just talking about, who is comatose post-cardiac arrest, really they're having a dysfunction of arousal, wakefulness, as well as awareness, right? And that's exactly what we do when a patient comes into the ED with altered mental status. We sternal rub them, we ask them questions to see if they're able to wake up and if they're able to be aware with their surroundings and interact with their surroundings. So coma is really a broad description. And really, like I mentioned, it comes in a spectrum in terms of what it entails. At the very end of the spectrum where there's really no brain function, of course, the patient could be brain dead. But really, when we talk about coma, we're talking about no wakefulness at all, no interaction, no awareness at all. But they may have reflexive movements, so maybe their pupils still work, maybe they still cough and gag, maybe they'll posture. But when we get to what we hear in the press a couple years ago about patients who are in the vegetative and minimally conscious state, we're talking about a little bit more progression on both the arousal and awareness. So for a vegetative state, the patient can actually have sleep-wake cycles, but they're not really interacting. In a minimally conscious state, they progress a little bit more. And then as they continue to improve, they're actually emerging from their coma and then hopefully become, as part of their recovery, back to their normal self. So as I mentioned, a patient who is in the true sense of a coma, if we're talking about just that part of that spectrum, is somebody whose eyes is closed, does not open their eyes to any stimulation, and their movements are very reflexive. Flexion, posturing, extensor posturing, really nothing that's purposeful. So as you'll notice, all of the talks this morning is going to go through the ENLS protocols because this is our kind of planning in terms of sharing that with you guys as a way to approach each of these topics, as again, to how to approach a patient in its management in the first hour. So in the ENLS protocol, when you're presented with a comatose patient, of course you would start with your ABCs and your initial assessment. We all know A comes with airway, so are they protecting their airway? Of course, if somebody comes in with altered mental status, oftentimes our question is whether or not there has been a trauma, a syncopal episode. Maybe that's why they're altered now. And we also have this drilled into us since we were in medical school that a finger stick is our 6th vital sign in terms of for an altered patient. And then if we're talking about our locals, I mean, any urban population, there is, well, actually, even the suburban population, right? There's the opiate pandemic. And so a lot of times when they fit the clinical picture of maybe having pinpoint pupils, maybe we'll give a try of naloxone. Now it comes to how do we assess the patient? So we kind of alluded to this in the sense that A patient is in a coma if they're not awake.